Hello, everyone. My name is Joshua Mansour. I'm a hematologist oncologist who specializes in stem cell transplantation and cell therapy. Today, I have the pleasure of spotlighting our researcher of the month for June, Stefan Ciurea. He is the director of stem cell transplantation and cell therapy at the University of California, Irvine and Chow Family Comprehensive Cancer Center. He's an accomplished researcher and physician in our field, and I'm very thrilled to be able to speak with him today. How are you doing?
Very good. Thank you, Dr. Mansour. Thank you for
So,
inviting me.
of course, and congrats on being our researcher of the month. You've done a lot of exciting things recently, and we're hoping to hear a little bit more. So why don't we get started about you telling us an area of research that you're most excited about right now?
Okay, so I think this is kind of timely because we're now, I'm super excited about cell therapy after transplantation. We have started with NK cell therapy, and we've published at least 2 papers. One was in Blood using ex vivo expanded NK cells in patients receiving a haploidentical donor transplant as a phase 1 study, and then we continued the phase 2 study. Published recently in leukemia. Actually, we expand the cohort to 25 patients who received the haploidentical transplant plus 3 doses of ex vivo expanded NK cells, and we saw a very low relapse rate in the range of 4%. Actually, the only patient that relapsed was a patient that was not eligible for the study because had blasts in the blood at the time, which went unnoticed. But anyway, patient was kept on. So relapse rate was extremely low. We compared this we gave the data to CIBMTR, gave us a control of patients, matched cases, and relapse rate was 38% versus 4%. So this is really exciting. This is for patients with AML, MDS, and CML or myeloid malignancies. We really believe that we can improve relapse rate. I would like to continue to study this in the future. But this brought up the idea of trying to improve transplant outcomes using cell therapy, not only NK cells, but maybe CAR T cells, or improve you treat complications of transplantation with, for example, BK virus CTL. So we have an upcoming phase 1/2 trial with BK virus CTLs that we're going to manufacture hopefully at the UCI in our new GMP. We try to improve, we're doing a lot of haploidentical transplants at UCI. About 25% have significant BK cystitis, and there's no, as you know, there's no good medical treatment for this complication, and we are trying to put together a study using BK virus CTLs, which will have a novel, I mean, they have been investigated in the past, but we're trying to bring something new in the sense that we're going to try to escalate doses and see if there's a higher dose better, if it's as safe as, I mean, in terms of not causing graft-versus disease, and if we're trying to increase exposure to different, progressively to different antigens, so stimulate these cells with different BK virus antigens, and see if there we obtain a more potent antiviral response. And last, I would say, why not putting BCMA CAR T cells after allotransplantation? Allotransplantation is now kind of losing in interest for different physicians because of course CAR T cell therapy is it's extensively investigated, but we have an upcoming phase 1 trial using BCMA CAR Ts after allogeneic stem cell transplant. We're going to try to do a trial using this approach in multiple myeloma to cure the disease. Hopefully this is going to work. So this is again trying to expand overall in the area of cell therapy after transplantation. Recently, we maybe on the same lines, yet yet to improve transplant outcomes, but in patients with refractory AML, we did a phase 1 study using NK cells for patients with refractory acute myeloid leukemia. This was published, our phase 1 data was published in abstract format at ASH 2020 as an oral abstract, was number 68, if someone wants to look up. We treated 12 patients, and now a paper is ready to submit. We submitted for publication. We treated 12 patients relapsed refractory AML with 6 doses of ex vivo expanded NK cells. So the cells were generated exactly the same as in the study with NK cells after transplant. And in the AML refractory AML study, we infused 6 doses because these cells are not going to persist for long, much like in CAR T cells. We try to explore the idea of repeated infusion. So we infuse every other day over 2-week period, 6 doses. And we saw that out of these 12 patients, approximately 60% achieved CR or CRI, and they went on to received a haploidentical transplant. These are all haploidentical NK cells from a haplodonor who was also, if they will respond, will be the donor for the transplant also. Doses were 10 to the 6 per kg per dose and to 10 to the 7 per kg per dose. Important to note that these were highly refractory AML patients with median of 5 lines of prior therapy, and about half of them had a prior allogeneic stem cell transplant. They failed an allo transplant. So this is some of the work I'm excited about. I recently moved to UCI 3 years ago, and we are expanding the program, and we started already a number of I think exciting trials that we will in these areas focused on improving transplant outcomes for patients with different hematology malignancies.
So you talked about this is all great and very exciting news that I'm sure everyone loves to hear about. And you've mentioned so much about the different cell therapies, using them in conjunction with allotransplant, whether it's before, whether it's after. That's still an evolving area in our field currently. From all of the trials that you discussed, or potentially new ongoing trials that are currently enrolling, is there any that you're most excited about that people can potentially even refer patients to you for?
Yeah, so I think, yes, I think we do not have, I'm excited about all these approaches. All of them are going to be developed over the next year or so. Most exciting is to further expand on NK cell studies for patients who are refractory, and there's no other good treatment anymore, and hopefully NK cells will offer a good chance for them to go into remission and eventually get the transplant. And this is particularly, I think this is particularly important for all the patients, because we've seen no toxicity for NK cell infusion. So if this works as we've seen in this phase 1 study, it will be very easy to administer even in 70-plus-year-old patients. As we know, these patients are more difficult to receive intense chemotherapy. I'm also excited about the BK virus CTL, although this work has been done in this area in the past. But I think I do not know if, these are donor-derived BK viruses, so we get the same donor to donate mononuclear cells for us to manufacture the virus-specific T cells. So there's no the T cells that we are going to be part of the same immune system as infused for transplant with transplantation. So there's no, these are not third-party BK virus CTLs. I think this is another novel aspect. And also for patients, so NK cells administered after transplant, I want to continue this for patients with AML and MDS. In a phase 2 clinical trial we're putting together now, but for multiple myeloma, I think it will be very interesting to see how an allo transplant followed by BCMA CAR-Ts will work, because these BCMA CARs, which are going to be manufactured again from the same transplant donor, are not manufactured from a beaten up patient who've seen 3 or 4 lines of prior chemotherapy, because most of them have to fail a high number of therapies, but they're generated from fresh mononuclear cells from the donor. So I'm hoping these will be hopefully more effective and because of the allotransplant, we will treat the patients with hopefully low tumor burden and maybe will be an effective curative therapy for.
And hopefully some better outcomes because of that as well.
Right.
That's fantastic. Thank you so much for your time today. Really appreciate it. And congratulations again for being our MOASC Researcher of the Month.
Sure.
We'll make sure to provide your contact information after for anyone that may want to reach out.
Absolutely. Thank you.
Thanks again.
Thank you so much for having me. Appreciate it.
Absolutely. Thanks again.
Bye.